Yes, sir.
Yeah, thank you. Good evening, one and all. Yeah, very good evening, one and all. I'm Saurabh Sandalia. I'm in charge of academics and strategy at My Rehab Academy. Today, we are here to learn about facial manipulation. But before that, I would like to tell just for 2 minutes something about my academy called My Rehab Academy. My Rehab Academy is a platform which connects the physical therapy graduates and professionals from across the globe to the best of instructors, guides, and resource person, again from across the globe. And this connection is all for your enriching the skills so that you could be much better either you are in academics or in the clinical, wherever in the world you are. Before digital, we all were doing physical workshops and conferences across the country. But ever since Corona pandemic, as every one of you aware, because none of them have been left out of this, we have started digital and successfully delivered more than 700 hours of classes till date ever since pandemic started. We have been doing this mostly on the weekends, and this time even it was on the Friday evening. And I can tell you, whenever we did our workshop, whenever we did our digital class, people joined in hundreds. And the conferences, whichever we did, whenever we did, people joined in thousands. My Rehab Academy is a branded, it's a brand name, as every one of you are aware. We got the best award, the best education in rehab sector. That award we got for our viral presence over the social media, as well as the vibrance among the candidates and participants who joined. We realized, yeah, definitely at Academy, we are doing the best for making you learn. So now we thought, why can't we do something so that you could, migrate yourself from learning to earning? So from learning to earning, this was a thought, but let me tell you how it looks like learning to earning. And we have invested hundreds of hours in brainstorming. How can we do? So we are coming up very soon with something called My Rehab Care. That is a unique platform where you will be able to get registered in unique way, and you can register yourself, you can see your profile, and you can get patients in your nearby area or the areas you choose for seeing the patients. It will connect you in such a way, it will be proper, right from clinical management to, it will be a GPS enabled software, so that in real time you could see how far is your patient, and you can see in your data how many times he has come, how much has he paid you. Means completely digital. So this project, of course, it looks so easy to listen, but we have brainstormed really a good number of hours. So this thing will be released anytime soon. And like the best part is this, in this thing, once you are getting registered, it's up to you. Once you are switching on the app, whenever you want to see the patient, you can switch on the app, patients will inquire, you can go for that. And if you don't want to see patient, or you don't want to see patients from My Rehab Care, what you can do, you can just switch off the app. Once you switch off the app, patients won't come to you, it will go to the neighboring people, whoever is switched on. So that is a complete GPS based concept. Of course, once it is in the market, then more and more information will come to you. This is what I wanted to share before we start today's session. So I think, yeah, Dr. Kannabiran sir has joined. Yes, sir has joined. Sir, myself Saurabh Sandli, I welcome you on behalf of complete team, on behalf of full core team. Dr. Kannabiran Bhojan, sir, have you joined, sir?
Yeah, I'm already there.
Yeah.
Good evening, all.
Oh, okay. Good evening, sir. I would like to give a small profile for sir. Sir is a research guide at famous Tamil Nadu Dr. MGR Medical University. He is professor at RVS College of Physiotherapy. Sir is a consultant physiotherapist at Yasoda Physiotherapy, Fasciokinetics in beautiful city of Coimbatore. Sir, we welcome you from core of our heart, and over to you, sir. Kindly take over.
Thank you, Saurav.
Thank you, sir.
Good evening, one and all. I know it is a Sunday, and the program is hosted on Sunday. Most of them, it's a weekend, and you want to enjoy. But still, this uh, the program, the introduction to facial manipulation, will be definitely enjoyable, and you will feel the essence of the need for thinking therapist rather than a global technician at the end of this program. Definitely, I hope so. Shall we straight away go to the presentation? So today we will be discussing on the introduction that is particularly on the facial manipulation. So here the first slide you can see here today we have a paradigm shift in manual therapy, particularly the approach from biomechanics is moving towards neurophysiology. So what is the difference in approach? Manual therapy is manual therapy, but why do you need to highlight neurophysiology? What about earlier? People used to do thrust manipulation. Even now, we do thrust manipulation, but most of the justification were given based on the biomechanical model. But right now, more the paradigm shift, like the evidences are moving towards the neurophysiology, and you can see the evidences throughout this introduction, and every slide will have some valid point on why you need to understand neurophysiology more than biomechanics for particularly to manipulate. So you all know there were different things existing earlier, particularly when you say um, any field, for example, an emergency medicine or anything, we know there is a lot of changes existing. The first 10 slides will tell you why you need to have an introduction on facial manipulation. So there is a change in exercise therapy, there is a change in electrotherapy, there is a change in hydrotherapy, there is a change in manual therapy. So, okay, what is the change in manual therapy? Earlier, we had a paradigm. This paradigm was enough to say that unsystematic observations are okay. So, like you go to a clinic and you do some hospitation with a senior, and you learn something, and then you start practicing. This is unsystematic observation. Earlier, they thought I am trained by so and so, so they said, okay, you can treat, and basics is enough to treat. It is not necessary to do something at research level. Is also a previous paradigm, and common sense is enough to treat was overall existing because people thought anybody can treat with a common sense. And then clinical experience. Okay, I have 20 years of experience. Doesn't mean that he is an expert. So these are all previous paradigms, and you need to understand earlier the situation. Like if you consider some 15 years, or now there's a lot of change. Now uh, days are no more treating the symptoms. We have started treating the cause. So when we started treating the cause, the need for treating the cause gradually created a demand that why we should treat the cause. Then what is the cause? So if we are treating the symptom, it doesn't make provoke you to learn what exactly is the cause. But when you started treating the cause, you need to understand very clearly what should be the cause for the pain rather than I have treated the pain. So finally, we got a new paradigm. So the new paradigm is clinical decision making. So in clinical decision making, uh, we found that intuition is misleading. You cannot always say, if I do this, he will get okay. You can never say that. The rationale for treatment and discharge may be incorrect, definitely. Understanding rules to interpret the literature is necessary. Even if you read the literature, you need to know that what kind of literature support is that you are following. Finally, why you need to do all that is because we know there are 30,000 biomedical journals published with 7% increase every year. And then roughly 3,200 physiotherapy articles published per year. And so keep up to date. If you want to be up to date, you need to read at least 10 articles per day. which is practically impossible. So somewhere in the world, somebody is running and somebody is not running. So you have a mismatch. So somebody feels, what is he trying to do? Something is not. Most of the freshers who come and join a clinic, they think that what is all that new, what we have not studied in college? What is this happening here? So this is the reason. So at least two articles would keep you, like you keep cope up with what is going on. So this is one important thing why we need to update ourselves and why you need to understand. And if you're not keeping up to date, finally what happens? You have a lag in your optimal practice behavior. It means you're not able to give cure in a uh, like in an early situation, or when somebody is able to cure something or somebody is able to treat something, we are not able to cope up. So basically there is a lag. There comes a lag in optimal practice behavior. So that is one bad thing. And opinion driven, people start clinical practice becomes opinion driven, and patients may be denied the best care, which is not safe for our profession. And patients may selectively know more than clinicians. A couple of times you can get patients who have been exposed to something more, and they come and tell you that, why don't you do practice this, why don't you do that? That will be a problem for us. So now, I know most of them who have registered would be having a soft corner for manual therapy. That's why everybody is interested to learn what is facial manipulation. Even though this is going to be a webinar, I may not be able to help you hands-on or something like practical, but this will definitely be an eye-opener. So what is essential is the content knowledge. What is content knowledge? Like basically, we need to understand what is fascia, and you need to understand that fascia is never included even in the medical curriculum. You need to study fascia separately. There are very few universities teaching it, very few teachers teaching it. So if you get an opportunity to learn fascia, that increases your content knowledge. Practical knowledge, you must get enough cases to practice, because the first 2 3 years of facial manipulation is going to be like a trial and error. And I'm sure that even if you learn it very, very sincerely and in a systematic manner, you always have some trouble practicing facial manipulation. Patients may complain because it takes a little bit of time for us to understand. And technical skill is going to be easy. You can acquire the technical skill when you practice roughly with a couple of patients, and you know what to do, and then your technical skill gears up. And you need to, of course, you need to know the basic general principles. And critical analysis is very, very important, because like where to apply facial manipulation, where not to apply is also very, very important. So you need to integrate the best research evidence. Okay, we will. So what is the first 10 slides trying to teach you is that do not be a global technician. When we say facial manipulation, the first prerequisite is that you have to be a thinking therapist. So what does a thinking therapist exactly mean to you? Like when you say thinking therapist, you cannot just straight away go for some patterns, because you need to do some analysis. Means you need some assessment, reassessment, and evaluation, which will be essential in this practice. Okay, coming to the point of facial manipulation. So how did this facial manipulation evolve? Who invented facial manipulation? Why? So the person in this for the slide, you can see he's Italian physical therapist Luigi Stecco. He is born in 1949. He is still alive, and he's doing a lot of research work. And I had an opportunity to visit him and learn one of the levels, level 3 facial manipulation. And I was surprised that the whole family is into the facial manipulation business, and the dedication and the way they teach and the cause for preaching facial manipulation is really inspiring. You get an opportunity, definitely you're blessed. So during the visit, the person Luigi Stecco is highly influential. You can see at the right side is where I have taken a photograph at the University of Padua. This university is one of the historic university where most of the lectures like Galileo, father of circulation, who graduated from this university. And I was surprised that the inventor of facial manipulation is a important core faculty of this university. and he took all the members who attended the course to see the anatomy theater, world's first anatomy theater, and the places where Galileo lectured and the places where William Harvey graduated. And I would say that's also a blessing. And you can see on the left side of your the slide, in the slide you can see a manus sapiens potens means a knowledgeable hand is powerful. That is what it means. That's what facial manipulation association, he formed the facial manipulation association. And you can see it is worldwide spread like this. And it is I would say, like the time when I took the levels, it was not even then introduced in the United States. Only in the recent 2 years, even United States is doing most of the facial manipulation courses. So this is one thing that increases your the clinician to have your confidence more, because you are exposed to something earlier, you have more opportunity to explore. So facial system, I will be like switching over between a little bit of fascia and then the facial manipulation, both, because I know, because we never studied fascia in our curriculum. None of the, even the medical curriculum doesn't have fascia in their syllabus. So it is essential that we need to have a little bit of understanding about the facial system. So what is fascia? So in general, somebody is asking you, what is fascia? It's a fibrous band. Okay. Okay, let it be a fibrous band. What are we going to do with the fibrous band? The surprise is that this fibrous band is innervative connective tissue made of collagenous fibers and elastic fibers. So when we say collagen fibers and elastic fibers, they can remodel. At the same time, when I say it is innervative, you know, they can be a definite source of pain or proprioception or kinesthesia, whatever. And when we say it's a fibrous band or it's a taut band, there are still researches going on. Like they have a debate whether, because fascia can be studied only in a fresh cadaver, fascias disappear after death. And so you, every time you need to study fascia or you need to have a dissection course in fascia, you need to attend a fresh cadaver course. You cannot attend a you don't see a fascia in a stored or in a cadaver. So fresh cadaver means that after death, after a certain time, so they still have a doubt whether fascia is a fluid or fascia is a layer. So this is one thing that is existing, and this is for your information on fascia. So we all study. Okay, everybody studies about bones, muscles, their origin, disposition, whereas the fascia is fascinating. And like in our body, for example, we take a clinical scenario, like we want to treat a lesion, for example, periarthritis shoulder. Okay, periarthritis shoulder, we call it as an arthritis around the joint, or you can call it adhesive capsulitis. Okay, if it is adhesive capsulitis, what do we treat? Do we treat the soft tissue, or we treat the joint, or we treat the neural tissue? So pain is coming from the neural tissue, movement is not coming because there is adhesion. Okay, so that is like reductionist fantasy. So somebody tries to reduce it into like bone, into tissue, but it is not so. What is binding all these structures? There is only one structure binding, and that structure is called fascia. So if you know how to treat the binding structure, you can address the bone, you can address the soft tissue, any soft tissue, you can address the artery, you can address the nerve, any structure, because they're all bound with one structure called fascia. Okay, these are all different cells, basically, that is coming from the ovum and the stem, sperm cells, basically. And then they specialize into different organs, tissues, and we organize into colonies and then society, whatever. So this is one thing. But what is common binding this all these different organs, everything, is you need to remember that the connective tissue, particularly the fascia. Okay, so that is what it says, like the fascia holds our cells together. So once you know how to, why you need to manipulate fascia, because they hold our cells together. So it has got solution for most of the things. And What is very important relating the fascia and nerve? So you all know when it was first introduced, fascia, when it was first introduced, it was called manipulation of the fascia was called as neuroconnective manipulation. Neuroconnective manipulation. You can see here most of the fascia you have a nerve embedded within, or because the fascia has a bilaminar structure, imagine the nerves without the fascia, they'll just be dangling. So only when there is a fascia the nerves get a very clear presentation. So most of the times we can see that sometimes the heat therapy works, sometimes cryo works, because when your body temperature changes, or sometimes you see patients living in a cold temperature say that they have more pain, is because what is binding your nerve is the fascia. What is fascia connected with? You will see the superficial skin and the fatty layers, and then to the epimysis and to the muscle epimysia connected to the bone. So imagine your fascia is getting tight. Basically, when they can become tight, because fascia is connecting to the muscle. So when a muscle is generating some heat, or when the muscle is not generating some heat, so the classical example is like, for example, if you try to keep cheese or butter in the freezer, basically it's frozen. So there's no movement. So imagine our body. What do we have? Major part of our body is fat. So if you try to keep it cool without any generation of heat, then basically your fascia can also restrict the movement of the nerve, creating pain. So this is one thing important. And you can see this is one slide on the right. You can see the group of muscle fibers. Basically, we know they are surrounded by perimysium, and then in turn they're connected with epimysium. You can see here the facial collagen fibers here, brick red, and then the elastic fibers are black. So that is how they are connected. This is one section just to show you some idea about how the muscles have the fascia. And why do we need to know this? Is because we are connected very well by what? Like you have the neural net, you have the fibrous net, and the circulatory net. And the neural net is connected with the circulatory net through hormones. The circulatory net sends the information to the neuropeptides to the neural net. The neural net is connecting the fibrous net with the help of the motor nerves. The fibrous net connects with the flow patterns on the circulatory system. And then you have the protein supply, which is very important. So the stretch receptors are directly connected from the fibrous net to the neural net. So now what is binding all these nets? So we saw in the earlier picture, if you remember, there's three net: neural net, fibrous net, and these three nets. So what is connecting them is again the fascia. So fascia is the only tissue that modifies its consistency when under stress. So it is malleable, it has got plasticity, and it is capable of regaining its elasticity when subjected to manipulation. So that is the key behind when somebody comes with a frozen shoulder or a periarthritis shoulder, not able to lift the hand, and with facial manipulation, it's like magic. The force transmission is restored. It is restored. The similar stories in osteoarthritis, ankle sprain. So microscopic structure of fascia, this is all just for an information you can see, then of course you can learn. Just make a small note so that you can learn about this microscopic structure. You have superficial fascia, you have deep fascia, and then you have the epimysial fascia. And you can see that is how they are arranged, and you will be treating the superficial and deep fascia when you're doing facial manipulation. So there are fascia of the trunk and limbs. You can see there both has got hypodermis and then deep fascia. In the limbs, you have additional epiphyseal fascia of every individual muscle. So all these facial structures are very important, particularly in force transmission. Remember fascia and force transmission. And this is one aponeurosis. That's a superficial layer of the right-sided pectoralis major. You can see on the slide, and is passing over the sternum to continue to the aponeurosis of the fascia and the contralateral pectoralis major. So it is like connected throughout. This is in the trunk. And it is important to mention that the facial like quality in both the trunk as well as the limb, they totally are different. They are not the same. So this is again aponeurotic fiber, the trapezius on the posterior aspect. You can see there. This is the trapezius, and then this is on the limbs. You have the epimysial fascia. That is here is the calf muscle. You can see the fascia of the calf muscle. So next coming to like the internal layer of fascia, you have many septa, facial compartments, you have muscle groups collaborating, and you have like what we study in biomechanics as total muscle force vector. The force transmission is purely by the fascia. So going to the, this is just a slide to show you the muscle tissue. Um, Particularly, you can see here the large layer of deep fascia, and then you have the, you can see the superficial fascia, and then you can see the epimysial fascia and the muscle tissue. This is how it is arranged. And this is the microscopic structure of the fascia. These are few slides to make you understand how they are. When you try to lift, this is some dissection. If you try to lift with the fascia, the whole body can come up. Where you try to hold the muscle, it can break. You can just pull it, the muscle will cut. But if you hold the fascia, the whole structure comes up. It's so strong. This is again the microscopic structure of the deep fascia. You can see there. So that is how it is very strong and is connected throughout. It's a three-dimensional structure. And the epimysium comprises of the fascia that is enclosing each single muscle, and it is continuous with the perimysium and endomysium. This is already understood when you study muscle. Okay, so now we will come to a classical example. Um, Movements in our body. So basically, why we need to study about facial manipulation? It is because we need to understand, like we need to restore movements. So okay, coming to movements, how do we movements? We generally study movements as flexion, extension, abduction, adduction, medial and lateral rotation. So this, according to the fascia, they call it as 6 unidirectional myofascial units. So the terms will change, and the attachment is very important for physical therapists to understand how they get connected and how they work, as in relieving the adhesions to make the force transmission smooth. So we can simply say that the fascial gearbox arrangement. So the well-being of we all know, like when we say facial manipulation, we will be thinking whether we are going to treat only the musculoskeletal. Of course, when you study earlier, you treat musculoskeletal. Later on, you also can treat internal dysfunction. Internal dysfunction means like every organ has also got fascia. So if you can treat the musculoskeletal system, particularly here, they treat the muscle like an organ. The muscle is generating force, but the force transmission is through the fascia. So we have the muscle, we have the nerve, we have the bone, but the movement is not existing. So what is responsible is the fascia. Similarly, every organ has got a facial connection, and the organs as well as the musculoskeletal fascia are connected with each other. They are connected. So by treating the musculoskeletal structure, you can see healthiness in your organs. At the same time, healthy organs also reflect in the skeletal structure. So let us now first discuss on why there is a problem in the fascia. Then only we have a reason to treat the fascia. So how do the facial problems start? Okay, it can just like that start by the way we are sitting. By the way we are sitting, very simple example. So what is a simple example? Imagine a software engineer able to spend about 3 hours in front of a computer. So basically he is trying to misuse or overuse or abuse, or we can call it as cumulative trauma. So trauma could be the first possible reason. Slowly evolving trauma like disuse, overuse, misuse, and sudden trauma like abuse. So these can lead to inflammation and inadequate remodeling. Finally, the fascia, when you try to palpate, you can see something called densification. So that involves distortion of the myofascial relationship, reducing the sliding and the proprioception. So it is basically targeting the force transmission chain. The force transmission chain is disrupted or is in a dysfunction. So densification and loss of facial sliding functions are very well demonstrated, and there are studies, particularly when the tensor fascial lata was thick. Again, now the combination of irritation, inflammation, and acidification and densification. So when you call densification, you all have a doubt. What do you mean by densification? So there are different theories earlier. We all know, we all sometimes have been very um, maximally exposed to something called trigger points. So we must be thinking where there is no muscle here, but why do we have a trigger point here? So those knots are those points where densifications in the fascia. So what do you exactly mean by densification in the fascia? So for example, imagine you have this is supposed to be a smooth sliding structure, and this smooth sliding structure is and suddenly you have a trauma, so it is going like this, and it tries to stay like this, so that one point it becomes disrupted and there is a knot at the other point. The knot becomes like this, and when you try to move and see it is not smooth anymore, that area is called densification. Sometimes you get a patient who clearly says that I've been walking 8 kilometers a day, but I have knee pain. I was walking regular, I have my weights normal, I am not overweight, I don't have any other health related ailments, but I have knee pain, but still I'm walking. So you are surprised why this person is overuse could be a reason. So that is why overuse, misuse, disuse, or like you don't move. Immobilization can also bring densification in the fascia. So chronic tissue loading, particularly in back pain, there was a study, and by Myers in 2009, who clearly said that one other possible reason why possibly to say the fascia can be loaded chronically. The other aspects like you need to know is mechanical stress. Like there are studies by Langvin in 2008, the collagen and matrix remodeling is totally distorted, leading to fibrosis. So, and this was also like what to say, supported by the other visceral manipulation experts when they did studies. For example, Barrel did studies on tuberculosis patients, on the cadaver of tuberculosis patients who died earlier, and then he was able to see that there is a thickening or fibrosis, which is the reason for their early. So all this, and why he has related that the breathing or the movement of the fascia, particularly the trunk fascia, contributed for the early death. So first thing is that we need to very clearly understand about understanding the load sharing is very important. When I say load sharing, the reciprocal function of the myofascial continuity is widens the clinical choice. What do you mean by load sharing? For example, when you're running, when you're doing some exercise, if the natural way of load sharing or the natural way of your facial force transmission is existing, then you don't get into trouble. When we go to the gym and we start doing isolated muscle training, then your fascia, which has got a pre-existing pattern, fails, or your brain doesn't recognize how to recruit the muscles or the facial force transmission. That's how people get trouble and the performance comes down. So that is very, very important. When you want to rehabilitate, you need to understand whether there was isolation, and if so, why, how, and then that is the most important aspect when you say scope about facial manipulation. And then we have to see some. So now we have some idea about facial manipulation, about how the facial problems start and why fascia is important. And now we see fundamental aspects of fascia. So fascia plays a major role in coordination and proprioception. Also, it plays a major role in controlling posture and complex movements. So that is Why it has all these properties? Because it is the plasticity of facial tissue is remarkable, because you can see a person trained for gymnastics can bring the fascia into a different level of different capability of stretching, whereas a person who is lethargic or a white collar job who doesn't do any physical activity, he is totally different. So that's one thing. Fascia can adapt to stretching. Fascia can be manipulated. Fascia, it is possible to manipulate the fascia because it has got the property of malleability, and the collagen bundles and the elastic fibers can, when we start working on them, can definitely help to stop pain. Okay, in facial manipulation, when we say introduction, this is very important that you need to learn. You can see the different parts of the body segments here. CP, that is head. The head here they call it caput. The neck they call it at column, and the shoulder blades they exactly at the upper part they call it scapula, and humerus, cubitus, carpus, and digiti. Whereas here you have thorax, lumbi, you call it the lumbi, the lumbar area, pelvis, coccyx, genu, talus, and pes. So these are the body segments. Because we are going to manipulate, you need to document how we are manipulating. So when you want to document facial manipulation, you need to know the segments. So these are the segments that you need to understand. So that is how it is. So when you say SC, it's scapula, HU humerus, CU cubitus, CA carpus, DI digiti, phalanx, caput, and you can see here column, thorax, lumbi, pelvis, coxa, genu, talus, and pes. So this is how they are naming the body parts in the Latin term, and that is what they have used in facial manipulation. This is the body sequence that you need to know. When we say body sequence, this is you need to understand about body sequence. Here is the body sequence. You can see here in sagittal plane. So this is the sagittal plane. So you have in the sagittal plane you have anti and retro. In the frontal plane you have medial and lateral. In the horizontal plane you have intra and extra. So anti motion and retro motion. So this is anti motion. This is retro motion. Are you able to see that? This is anti motion. This is retro motion, medial motion, lateral motion, intra motion, extra motion. So okay. So what do we exactly say facial manipulation? So as I discussed already, facial manipulation was first called as neuroconnective manipulation, or it was also called by a few other people as segmentary treatment. So they were initially targeting pathologies of the locomotor apparatus, were then considered as an isolated dysfunction of a single body segment. Later on, the studies and the research proved that they are not a single body segment, and it is basically a connection. So how is this facial manipulation working? So basically when we say densification, it is some thickening or hardening of the facial tissue. Here basically when we do facial manipulation, the ground substance of the fascia, the ground substance unites cells and influence the development, polarity and behavior. So basically it is working on the ground substance. We can say that we are melting the fascia or chiseling the fascia. These are the common terms used when we do it manually. Either you can chisel the fascia, or you can chiseling, like you can do that movement, or you are trying to melt the fascia. These are the two important things. So coming to the fascia as a force transmission chain, what is so unique about facial manipulation is that we start looking at the body as a whole, and you don't dig it in the place where you have pain. And days have gone where you address, when somebody says there's knee pain, the cause could be in the hip. When somebody says hip pain, the cause could be in the spine. So it's like we don't treat the place where it hurts anymore. So we have a very clear presentation of how they're connected. So facial alterations away from the painful area, or most of the times, can be a troublemaker. And this is a small video for you to see. Please watch this video on the fascia.
There will be no sound, right, sir?
Is it audible?
No, sir, it's not audible.
Is it audible?
No, sir. It's not audible, sir. So I think you have to come out from the screen share.
Now it is self-explanatory anyway. I'll tell you.
Okay.
So you can see here, this was a brief video on fascia. You saw about when we go to the, this is how the fascia is actually looking at. And then if you see the arrangement, and I have to see. So you can see that's how it is organized. Basically, the slide itself is explanatory. You can see here endomysium. Then you have the perimysium. So finally, you have the epimysium. So you can see at the place where you have scar tissue, most of the times you remember if you've been working on a, basically when we are posted in a post-surgical OPD where patient is difficulty in moving, we always focus to mobilize the scar tissue. So, and you surprisingly, when you mobilize the scar tissue, you see there is a large range of movement. And the scientific background behind that is that you're trying to realign the collagen in the fascial tissue, which is basically bringing back the force transmission chain. That is what is discussed here. So if there is adhesions in between the fascial structure, you call it as cross linkages. Sometimes you will have adhesions at the level of the uh, like in between. I'll show you the picture. You can see the adhesions. It's yeah, here you can see here. Sometimes, for example, you can see here this picture. This is where you have the clavipectoral fascia coming, and then it turns into the brachial fascia, antebrachial fascia, and then it extends till the thumb. You have the deep cervical fascia, and when you say clavipectoral fascia, below the you have the below the clavipectoral fascia, you have connections with the ribs, you have the clavicle, you have the ligaments, you have the connections between the for example, from the vertebra to the clavicle until the you simply call it as the vertebro-pleural ligaments. There are ligaments extending from the vertebrum to the pleura. They are also embedded with the fascia. So whenever you have a problem in the shoulder, we need to remember that how the shoulder can be connected. That is how we have various studies supporting that. Even you have a dysfunction in for the right side of your shoulder, a dysfunction. What is exactly beneath this area is your liver. What is exactly beneath this area is your stomach. So most of the left-sided periarthritis shoulder, if it doesn't resolve with ordinary treatment, think about the stomach involved. At the same time, on the right side, think about the liver involved. And this is strongly an emotional shock observer. And this can be the stomach can also be involved with your emotions. That indirectly the organs can bring presentation on the shoulder. which is also evident by the referred pain patterns that is existing and which is used in day to day. So basically, fascia is a force transmission chain, and we are able to treat acutely painful conditions and not even touch the area that hurts. For example, like you need to know where to balance when there is a tension prevailing in the fascia, which is disrupting the force transmission chain, which comes by practice in couple of years. And testing and treating, we may think we have nothing to do with the problem, but since body is one complex and complete unit, I've always seen in OPD like a couple of times patients who most of them who had back pain had a history of a lax esophageal sphincter and a gastroesophageal reflux disease. And when you try to work on the fascia connecting the musculoskeletal and the organs, it was a surprise that most of them had cure for back pain. And now there's a lot of studies and research published on that they are connected. So that clearly makes it evident that the fascia is a force transmission chain. And this is another video again on fascia, because I know like a lot of registrants may not have an opportunity because it's a magnified video on the fascia. We can see here, as very well explained in the text below, these tubules, if you try to stretch them, they can separate. Otherwise, they get adhesioned. So, and then if you try to cut it here, the other side is intact. So it's a three-dimensional structure. So it's very difficult to cut the fascia totally. And then uh, in few lectures are very clearly told that when we're doing classes on fresh cadavers, the moment they do a dissection of the fascia, they try to turn and turn back, the fascia gets united, means that they have a sticky nature. So hope you got that presentation on fascia, like how it is existing and how it is working. And now we go to the next slide. So this is for particularly you need to understand about the for a clinician, particularly when you're treating. So how facial manipulation works in the anatomic point of view. You can see here. This is the posterior as well as the anterior too. You can see there, and it's basically pivotal. Like you, if you see the slide, in the slide you can see here particularly you have anti, that is the flexion area, extension retro, and then you have the medial lateral, and then the intra and the extra on both sides. And this is where this is like six. You divide it into six, and this six sequence is very important to treat. This is very like, for example, if you want a flexion movement happening, you also should always think about the whether the extension movement, like agonist antagonist at the myfacial level. So now you can see a lot of studies have been published based on fascia, and there are a lot of literature right from 1890 it is there. So this is an evidence that we can study about fascia even though it is not there in the medical curriculum. And there are a lot of controversies on fascia. This slide very clearly explains that whatever it is, it can be a fluid, it can be a layer, but still the muscle is attached to the bone only through the fascia, and it is not directly attached. The muscle is not directly attached. If the joint has to move, the muscle is the center of the force. The muscle transmits the force through the fascia, and the fascia is moving the joint, and that is understood. So you can see here this structure. This is the image of a 70-year-old athlete who has got a very, you can see there, this is the IT band and the tensor fascial lata. Here is the fascial lata. You can see the dissection here, and you can see how the structures are evident after dissection. And this is when without dissection. You can see that is how it works, and how they're connected. And this force transmission chain is very, very important. And why this remains important will be also discussed later. So layers of fascia, when just to understand for manipulation, just take it down. You can Google down. You get a lot of literature on aponeurotic and epimysial fascia. Two important things that you need to know. Aponeurotic fascia is connecting the whole group of muscle, whereas epimysial fascia is on every individual muscle. So the facial layers, again, superficial and deep. You need to always remember superficial and deep fascia and how they're connected to the skin as well as how the muscle is connected to the bone. And how did this facial manipulation arrive, or how was the building block? Earlier, you remember about bone setters, osteopathic technicians, relaxation, postural gymnast, some connective tissue massage. After all these things, so many people, and then finally on top, facial manipulation. So like bone setters, biomechanical model, friction massage, biomechanical model, Cyriax, biomechanical model, acupuncture meridians, biomechanical neurophysiology, but not very, very clear. And later on, this facial manipulation, biomechanical model of fascia, neurophysiology of fascia. So that's where we have the paradigm. And what are the main principles of facial manipulation? So when you want to do facial manipulation, you need to know some points. That is the point in the fascia to manipulate. So what are those points? They are called centers of coordinations and centers of fusion. So we will see in detail about what is centers of coordination and what is centers of fusion. So the idea of segments. So we saw earlier the segments, head and then neck, shoulder, knee. So we saw earlier these. So these are called as the centers of coordination. Based on that area, you have a center of coordination. So for example, if the point is in the neck, in the anterior, then you call it as antecolumn, ANCL, antecolumn. If it is in the anterior part of the lumbar, then you call it as antilumbi, antipelvis, antigenu, antitalus, antipes. So like that, you bring the CC. Most of the centers of coordination is in the center of the muscle, so it is not close to the joint. Whereas CF, or centers of fusion, are close to the joint and away from the muscle. So what is the difference between CC and CF will also be discussed But if you want the whole list of centers of coordination and centers of fusion, it is if you Google the fascial manipulation practical part, Steckone 2009, you have a very fantastic presentation about the CCs and CF. So the fascial manipulation system, the main principle includes the case history. So you need to listen to the case history, including the timeline. The most interesting part of facial manipulation is you have a timeline. At 5 years, I had a accident, injured my hand. At 11 years, I had an accident, injured my leg. So this can give you information on why this person has pain here after 20 years. So that is very important. And then you have movement verification. You try to move and you are able to sort out which segment or which, for example, anti-motion or retro-motion is in trouble. And then you can palpate exactly column, neck, lumbi, pelvis, palpatory verification of that area. And then you treat and then you reassess. So the main goal of fascial manipulation is to balance the body to allow painless function, but basically painless movement. So from the case history, the hypothesis decided upon to determine the segments, and after the case history, after the palpatory verification, the fascial manipulation treatment is performed with fingers or knuckles or elbow on the predetermined points. So the predetermined points are fascial manipulation points, and the treatment is done with the applicator as a finger, knuckle, or elbow. Sometimes these days there are also advanced gadgets like the phaser, and the phaser 5 is a gadget which is specially used to mimic the work of your finger, where if you don't want your fingers to be in trouble, then you can also do fascial manipulation with the gadgets. But as instructed by the Stecco, it is always safe to do fascial manipulation with your finger. Fascia and force transmission. Okay, when we say force transmission, we can have some discussion about what is force transmission. So most of the times you would have come across situations like you can take a classical example of an ACL reconstruction or an ACL injury, an athlete with an ACL injury. So you see sometimes an athlete with a torn ACL says the knee is stable. Sometimes another patient, even with the intact ACL, says the knee is not stable. So we all think that when the knee is not stable, we think that the ACL is responsible for the stabilization. Yes, the ACL is responsible for stabilization. It has some proprioceptive role. It is agreed. But when you walk, the force transmission chain for people who don't have an ACL, how it is functioning or how it is existing and how it is working is the myth. Like you need to understand, like people thought without an ACL reconstruction you cannot survive earlier days, but nowadays people are able to survive or able to perform even without an ACL when you have a deficit ACL, but still when your force transmission system is intact. So we are basically working on the fascia, that is the muscle builds. Like for example, if you can call the muscle as pickle, the jar as the fascia, that is the pickle is stored in a jar. So the life of the pickle or the longevity of the pickle is only how good the jar is. If you have a jar which is so nice, the pickle stays for a longer duration, or it can be enjoyed over a longer duration. Similarly, the muscle is in a very good fascial box. The muscle can perform very well even though you don't have a ligament. So these are the body segments that we discussed. So the head is called as CP caput, and you call the neck as column, and then scapula, SC, humerus, cubitus, carpus, and digiti. And then you have the thorax, lumbi, pelvis, coxa, that is the hip, and the genu, the knee, and then you have the talus, and then you have the pes. So this is a very classical body segments, and then this is the diagonal. So when we say diagonal, you need to understand that this is how the diagonal exists. Extra is diagonal to intra, anti is diagonal to retro, latero is diagonal to medio. So if you want a movement in the medial side, you need to always think about the lateral side, and you need to always think about the supporting two sides, the retro and intra. So if you want to do anything on the medio, remember that you need to address intra and retro for performance. Always think about the lateral. And so you can see all these things are evolved. So if you want, for example, shoulder flexion to happen in a periarthritis shoulder, so the flexion is an anti-motion. So what is the most common thing that you need to work is this anti. So this anti-motion, remember about the segments. If you, for example, you take the shoulder here, this is the anti-motion of the shoulder. You need to remember about the anti-humerus, anti-cubitus, anti-carpus, and anti-digiti. So these are the structures that you need to remember. And then you have the retro aspect, particularly the retrodigiti, retrocarpus, retrocubitus, retrohumerus. So that is very important to think, and how it is connected to the clavipectoral fascia. Again, you need to think about the column, the deep cervical fascia, and the thorax. Particularly, the endothoracic fascia is connected to the clavipectoral fascia, and the uh, vertebro like there are ligaments connecting the respiratory apparatus with the uh, that is the pleural cavity to the vertebra. They are also involved in when you're treating the anti motion of the periarthritis shoulder. That is the diagonal explained here. So this is a classical example about when you find a point in the mid of the muscle. It's called as CC, anti-genu, is a center of coordination. When you find a point which is a combination of two structures, that is, you have retro separately and then you have lumbi separately. Then these points you can see here, retro lumbi, and this is anti-genu. And here you have a point anti-mediogenu, that is in the joint. So this is anti, this is latero, then it is anti-laterogenu. Here it is retro-medio, so it retro-medio. So this is center of the pain can be here, then you call it center of perception. So here in this slide, you have two important things to remember: center of coordination and center of perception. So this is center of coordination and this is center of perception. Sometimes this center of coordination, if you try to treat and the pain in the perception doesn't improve, then you have to come to a point called center of fusion, which is almost close to the joint. We discussed earlier that the center of coordination is always in the muscle and the center of fusion is close to the joint, that is above and below the joint. So this is the myofascial units, the centers of coordination: anti, retro, lateral, medio, intra, and extra. So this is the diagonal we saw earlier: anti, retro, exactly opposite diagonal, medio, lateral, extra, intra. That is how it is. So this is the sequence which is very important. There are 78 points in general in the CC, 78 CC. So when you start from the head and trunk, you can see the myofascial sequence: anti-caput 1, 2, 3, anti-column, anti-thorax, anti-lumbi, anti-pelvis. And then coming to the upper limb: anti-scapula, anti-humerus, anti-cubitus, anti-carpus, and anti-digiti. Similarly, in the lower limb, you have anti-coxa, anti-genu, anti-talus, and anti-pes. This is the retro sequence. This is the intra sequence. This is the extra sequence. This is the lateral sequence, and this is the medial sequence. So these are the sequences that you need to learn during the first level of facial manipulation the class. They try to introduce these, particularly this the so-called the points, and these points will be learned in thorough, so that you try to analyze if there is a problem in the center of coordination. So most of the times, the center of perception where you have pain will not be the same place as your center of coordination. So centers of fusion is nothing but an extension. Basically, they are diagonals and spirals. So we can see the centers of fusion now. So when we treat the fusion, we call it facial mobilization, manipulation and mobilization. So here we treat the centers of fusion. It's like mobilizing the fascia. So we know that the center of coordination is the center of the muscle, where you have a center of fusion, that is 2 or more myofascial units. So we know the myofascial unit, you have a center of coordination. When 2 or more units are joining together, then you have one regulation, that is one point which will regulate those two centers of coordination is called center of fusion. So, treating the center of fusion is far easier treating than the center of coordination. So this is how again it is. So you have, as we saw earlier, anti, retro, medio, latero, and then you have retro, anti, and then latero, and then medio. So when there is a combination of the retro and latero, you call it retro-latero. The anti and latero, you call it antilateral. Particularly, you need to understand here this is the center of fusion or the diagonal. So as the association formed by the facial manipulation, as the emblem says, the logo says, a knowledgeable hand is potent. So you need to understand the process of raising and the disturbance for single segment in which the movement is compromised, and several segments if there is a spiral involvement is existing. So we need to understand the movement scheme, particularly the movement scheme which is natural, and if it is disturbed, why it is disturbed, and whether a single segment or several segments is very important. So when it's a single segment, most of the times we treat the CCs. When it's multiple segments, we have to treat multiple CCs or CFs, that is center of fusion. So you have an assessment chart, and then we work on the assessment chart to finalize the mobilization. And this is what you call the diagonal, the center of fusion. So you can see here, this is the retromedial diagonal and the retrolateral diagonal. And the next slide is the antilateral and antimedial diagonal. This is the diagonal movement, because most of our movements are not robotic. We have a schema which is so beautiful. We don't do robotic movements. And you can see this is another antilateral spiral which is existing, and the spiral is formed like that. And this is another spiral, retrolateral and retromedial spiral. So the diagonals and spirals. This is the diagonals, this is the spiral. So this is very important when you are analyzing or doing an analysis to find out the critical uh, problem where the dysfunction is existing. So why we need the CFs? Why it is not enough to stop with the CC? Why should we start learning about CFs? So we know when you have a balloon tied up to one string, it has multiple movements. Two strings in one plane is stabilized. When you have multiple strings, then it is nicely stabilized, it doesn't move. So we need a uniform movement. That is where the force transmission becomes perfect. So that is why we need to study about the center of fusions and not stop with the centers of coordination. So what kind of conditions we treat? All conditions: spine, back, neck, shoulder, elbow, wrist, hip, knee, ankle, and foot, and whatnot, and internal dysfunctions. Everything can be treated with facial manipulation. So this is one example. This is just to discuss. We all study about the various structures. Here, particularly, you need to see the fascial compartment. When we study about the fascial compartment, particularly the fascial compartment of the neck, understand that the facial compartment of the neck is very involved. You have the fascias involved in the neck. Deep cervical fascia, there can be a problem in the deep cervical fascia. There can be problem in the antebrachial fascia, which can also manifest as brachial neuralgia. And so you see the schema here. You have the fascia embedded like this. You can see anti, retro, lateral. You can see the right lateral and the left lateral, and then you have the anti-lateral, and then you have the retrolateral. So this is how the movements, the diagonals are existing. So here you can see the facial compartment of the erector spinae. This is the erector spinae. This is the facial compartment. It is here in the column. Which column? This is the retrolateral column. So and then the diagonal exact opposite will be the antilateral column. The antilateral column, you have what? The structures are different totally. So you see in the antilateral column, you have the sternocleidomastoid. So we can see if you want a function from this muscle, you need to think about this diagonal. So it is how it is, that is how it works exactly. So internal dysfunction as it will be very advanced for the introduction course, but still I wanted to add one slide to just explain, because what they try to explain in the internal dysfunction is that imagine your human body or the trunk is just like a what you call the roof, and then you have the structure. So if the roof has to be perfect, your limbs has to be perfect. That is what they call here. They try to call the structure like an engineering structure, the tensile structures which will be connected, the limbs and the wall of the, for example, they call it the abdominal canister. It is connected with the limbs with the help of the fascia. So organ dysfunction can manifest with pain and symptoms and can be located in a different body segment. So you can treat them by treating them. So that is how they call it a tensile structure. They call it apparatus facial sequence and catenaries. Catenaries means you see that you compare to a roof, and then you have quadrants and systems, and which can be treated with the facial manipulation. Force transmission, when I said, you can see here, for example, a classical example of not able to lift the shoulder, you see the fascia clavicular fascia, you have the different forces coming from different direction, and then you have the deep cervical fascia. This is the fascia from the pectoral muscles, and then from the lower limb, the muscle generates. You can see this is how the force is governed. So, what are the important facts? We are nearing almost the maximum area what has to be covered. We'll have little more strategies to discuss. Hope we can continue. You must have a fantastic exposure to facial anatomy and the biomechanical and neurophysiological model when you start doing facial manipulation. Without understanding the biomechanical as well as the neurophysiological model, when I say the biomechanical model, you need to have the 100% knowledge, content knowledge on the biomechanics of the fascia, particularly the anti, retro, medio, latero, the intra, extra. These are the biomechanical existence of the fascia in force. So you need to understand that. The neurophysiology, particularly to understand how they are embedded. And then you need to know about the myofascial units. So basically the centers of coordination and the myofascial sequences with the centers of fusion of the upper and lower limb and how they're connected in different planes, sagittal, frontal, and the horizontal plane. And you must have adequate exposure on identifying the lesion using the fascial manipulation assessment chart. The important aspect that will make you confident using facial manipulation is understanding the physiology of fascia, which is very, very important. Human fascial system examination is well done with the help of the understanding the physiology. Finally, we can arrive at treatment strategies. So the role of centers of fusion using the myofascial diagonals and myofascial spirals, and we are only targeting something called as the fascial gearbox for a smooth transmission of the force, which is essential for any manual therapist because we are trying to restore movement. So strategies will be you are trying to detension. When you start initially, start from the proximal and progress to the distal, and start working agonist antagonist balancing. That is, agonist is anti, antagonist is retro. Balancing both sides of the body. When you're treating, for example, like trapezius, you can treat on one side and then it can be compensating on the other side. So try to balance both sides. And then you can see this is the picture of how the anti versus retro. You can see here, this is the anti, this is the retro. You can see how the forces are existing. And you can see here again the lateral and medial, and this is the intra and extra forces. So medial is most of the times proprioceptive. So with that, we get a very clear idea about how to form a strategy when you're using facial manipulation. So after the treatment, as I said you already, using an applicator, the finger or the knuckle or the elbow, you try to treat, and then after the treatment, after treatment as well, after following days, when you say this is how they represent. When there is a triple plus, you say there is a resolution of the pains of the case particularly. Bad then well means earlier very bad, now but better. Light improvement, and then before same as before well, but now after treatment. You can see the different presentations here, how to write, and then we need to have, and the interpretation is you are on the right direction, you have a physiological reaction, you have detention of the segment, you have to, and you worked on a compensative center of coordination. When you have worked chosen the wrong point, and then sometimes it's possible when you're starting to do fascial manipulation, it can create adverse pain or effect, so that the patient doesn't come back to you. So you need to first understand how to work on planes, and always focus on one plane rather than focusing on two planes, which will always keep you safe. These are few references that has been taken for this presentation, and with that, you have any doubts, I'm always this is where this is Luigi Stecco. On this slide you can see Luigi Stecco is trying to manipulate a patient, and you can see when he is manipulating, you can see that obviously the manipulation on the first picture is using his elbow, and you can see the firm position, how he is standing, and then how he is manipulating. This is the world first anatomic theta model, where it is existing in the University of Padua, and this is the place where the third picture is place where Galileo gave lectures, and this is where William Harvey graduated. And this Professor Luigi Stecco is an important core member of this university. And this is the last slide. Here you can see that when I had an opportunity, um, by the blessing of Almighty, to have a hands-on training under the inventor of facial manipulation, that was really fascinating to get it directly from the person who has invented it. And that's for your and this is where you can contact me. The email and the mobile number, which we can help you to start your journey in facial manipulation, basically targeting to avoid multiple surgeries, or can be a best source of relieving pain, and you can be very successful in your practice, and more than everything, you can do good for the society. And with that, I complete this presentation. I thank my Rehab Academy for organizing this webinar, and I thank each and every one and every participant who has taken time to listen till the end. Maybe, as I said to you already, there may not be any possibility of very hands-on, because it's a pure manual therapy topic, where you need to have some exposure on how to do certain techniques. But this is going to be a webinar which will be an eye-opener, because we thought, we would have thought that what is the reason for the force transmission when the muscle is not working, and that is the myth. The fact is that the fascia is the force transmission. So most of the times you can see an MRI with a torn supraspinatus tendon, but still the patient is able to do abduction. So that's how our journey started, to explore what exactly is the reason. And then we found out, and there are already a 35-year-old medicine system is existing in the world in the name of facial manipulation. And once again, I thank you all on a Sunday evening, patiently listening to the lecture. Any questions are welcome.
Yeah. Dr. Saurav. Yeah. Dr. Saurav. Yeah. Participants, if anybody has any questions. So some questions are there. One,
Yeah, where
what is the contraindication for FM?
1 second. As such, do we have that chat box? I couldn't search it like.
Yeah. So, what is the contraindications for facial manipulations?
Any manual therapist, if you are basically a manual therapist, whatever is a contraindication for manual therapy, the same contraindications you have for facial manipulation, because it's just another tool in manual therapy. Uh, so that
Hello.
can be in the broader aspect. And other than that,
आ जाइए.
you don't have any specific contraindications as such.
Okay. So, sir, next question is
What is the use of ISTM? How can we do with the facial manipulation? IASTM.
Yeah, you can. You mean to say instrument assisted soft tissue mobilization?
Yes, 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 sir.
Yeah. See, facial manipulation is basically taught to do with the hands, that is the knuckles, elbow, and the fingers. But as I said you already, phaser is a particular product. If you try to Google, you have a product which you can use a, particular tool. If I correctly remember, the tool which can replace to do facial manipulation will cost you around 45,000 just for one tool to stop using your fingers. And it is the information is available in the YouTube. If you try to Google phaser, Phazer, phaser. But you can also try to do facial manipulation with the any tool that is sold in the market. But it comes with expertise. It comes with expertise. You need a little bit of understanding about how the force exactly is transmitting and what is exactly to be done with the tool. So I would not recommend instrument assisted soft tissue mobilization as an alternative for facial manipulation during the early stages of your practice, which can bring down your confidence. Try to do it with your hand, particularly with your knuckles, and try to gain confidence, and then you can switch over to a material.
Okay. Our next question is do fascia ossify at any stage of life?
As I was explaining you during the course, they still don't know if fascia is a fluid, particularly a fluid or a structure. So still there is research going on at University of Ulm in Germany, and the key researcher is Robert Schleif, where I had opportunities to speak. They still have doubts, and their research is evolving to see if fascia is a structure or it's a fluid. But it is existing, and it is found only in fresh cadavers, and it is not present in the preserved cadavers. So it is understood that it doesn't exist once somebody is dead.
Okay. Sir, one more question is is there any relationship between facial lines and anatomy trends of our body?
uh, it is all the same, that is cooked in different way. So if you ask me like um, how can we eat dal, you can cook it in different way and eat dal. In the same way, fascia is the structure. You have different terms. Fascial
Okay.
manipulation you can call, facial chains you can call, anatomy trains you can call, but it is the same structure which is existing.
Okay. One more question, sir. Does facial lines promote good range of motion? Facial
100%.
lines. Okay.
Yes, 100%, because what they try to call as facial lines is nothing but the myofascial sequence.
Okay.
So when you say myofascial sequence, you can ask me again, what is myofascia, what is fascia? As I said you already, epimysium is surrounding each muscle fiber, and then the aponeurotic fascia is totally governing the muscle force, and they are connected in chains from segments. So if you want to work on performance, you can have tightness in your fingers, which will adhere the movement in your shoulder. So definitely the facial lines can do wonders in terms of range of motion as well as performance.
Okay. So there is a question, similar question has been asked by few of the candidates. What is the difference between myofascial release, facial manipulation, and trigger point release? Does fascia and trigger point have any similarity?
Yeah, what it has been always most discussed in most of the courses of fascia. Um, People who have exposed to trigger points always call they have trigger points. People who had exposure to Fascia has always said they are densified zones. So basically, to look at it as a clinician, I would call it as a magic spot rather than a trigger point or a fascial densification, because sometimes they are overlapping. If you see in the world of acupuncture, they call it meridian points. So these points, if you see, they all have something in common. So we do not deny that that system exists, this system doesn't exist. But scientifically, when you think, this makes justification. So when we studied the textbook on trigger points, they said the trigger points are existing in the muscle. So the muscle is the center of the force generation, but the force is transmitted only through a structure called fascia. The muscle directly doesn't generate for doesn't transmit the force. So here comes the important role of fascia. So it is better to call it as densification, where it becomes more easier to treat rather than trigger points. So this statement doesn't say that trigger point don't exist. It says that scientifically it is better to call densification rather than trigger points,
Okay.
because trigger point dry needling in the recent past have been slowly given up, and now people are focusing to needle the fascia. And the fascial dry needling, particularly the fascial adhesion model, has been fantastic, and it is proving giving you proven results that you can Google down, and they're the most sold courses these days. Okay, there is some interesting question. Facial manipulation can reduce spasticity. How? Okay, it is a very good question. So, as I discussed already, spasticity is because of particularly an upper motor neuron lesion. So here, if you ask me, can we reduce spasticity? Um, there are basically Luigi Stecco has one son and one daughter. The daughter is an orthopedic surgeon who is teaching fascia, and the son is a physiatrist who is doing research in fascia. So in the research in the New York University, they tried to do a research on spasticity using fascial manipulation, and they were able to bring some results that fascial manipulation can reduce spasticity. It is there in the Google. If you try to Google down, you can get the research paper. And um, so I don't say that you can cure upper UMN lesions with fascial manipulation, but we can still provide some input on working on certain UMN lesions in the aspect of spasticity, which the results are promising. And there is one more question: how many sessions of facial manipulation will improve the patient's condition? So it depends on each and every patient, just like joint mobilization. Short-term course for fascial manipulation as such is not existing. The only course provider for fascial manipulation till now throughout the world is the Fascial Manipulation Institute, that is the Stecos Institute. And uh, of course, we can organize smaller courses because Stecos Institute is always endorsing people who have studied to teach and preach fascial manipulation. So by request, we can organize smaller courses, but ultimate authority is the Steco Institute to certify you on fascial manipulation.
Okay. Okay. Cool. So there is a definitely a very good feedbacks are pouring in for you, and for this overview presentation about facial manipulation. And hope that once pandemic slows down, we'll definitely organize the physical workshop too, where you will be able to show them practically as well as it will be hands-on practice. So that's how. Uh, if anybody has any question, can say. Sadish here.
Please unmute and ask your doubt. Please unmute yourself.
So there is a question for you. Can facial manipulation uh, improve some of the neurological conditions like CP, stroke? I mean,
Yeah,
how much it can be
100%.
helpful?
100%. During our early training, which I witnessed. I could see people who had cerebral palsy with a very severe, for example, the scissoring gait. I could see the experts working on such patients and bring instant results on the spasticity where it instantly improved the walking condition. But it will sustain only with corrective exercise. But basically, the exercise should be addressing the fascia. So that is why when you study about fascia, fascial manipulation is manipulating the fascia. Fascial fitness exercise is basically sustaining the quality of the fascia. So it is a combination of both the fascial manipulation as well as the fascial fitness exercise. Yes, it is possible. Somebody is asking for an example of shoulder, knee, neck, back pain. Um, okay, we will take one simple example. For example, you can take it as a frozen shoulder. As I was discussing throughout the course, you have to just think about a frozen shoulder. For example, if it is going to be a right-sided periarthritis shoulder. Uh, okay, now let us come to a practical question. Where do we have the problem in periarthritis shoulder? So days are nearing where I can see a lot of radiologists now studying the fascial courses. The last courses we did on fascia, I could see 4 radiologists attending the fascial course. And I was surprised why the radiologist is coming for this course, because the next level of diagnostic criteria will be documented as there is a dysfunction in the fascia using high ultrasound or MRI, and that is what is already exists now coming into role. So definitely, so in that aspect, if you think and take it as a frozen shoulder, most of the times when you see a frozen shoulder patient who is chronic comes with an MRI stating that you have a rotator cuff tear, and you will be surprised that there's somebody with a rotator cuff tear and a frozen shoulder will never be able to lift the arm, and you will be surprised in no time. If the worst case is 1.5 years, the patient, even if you have not taken treatment, they restore the joint movements. Still the rotator cuff is torn. So what is clearly understood is that the lesion is not in the muscle, the lesion is not in the joint, the lesion is in the fascia, because the only system which was not diagnosed in the MRI was the fascia. So in future, radiology will play a major role to identify the lesions in the fascia, which will make this particular fascial manipulation more authenticated.
Okay, it was a wonderful presentation, sir, and amazing interaction. Your answer to the participants were definitely uh, eye opener. Like it's very interesting that people are asking various questions from various kind of curiosity. And okay, then uh, see you, sir. Is there anything?
Yeah, somebody has put a question: what is the relationship between fascia and viscera? So yeah, you have a lot of relationship between the fascia and the viscera. As I said you already, days have gone where physiotherapists have been treating joints. Now physiotherapists are treating organs too, because if you know, for example, if you want to walk straight, you need to have a good ligament, and if you can treat ligaments of your joints, why don't you treat ligaments of your organs? Because each and every organ has got ligaments, which is not included in our curriculum. If you've been given an opportunity to study about the ligaments of your organs, then you would have started treating those ligaments too. So when you say the fascia with the viscera, yes, definitely they are connected, and there are some courses that definitely you can make yourself successful integrating both the fascia and the viscera.
Okay, sir. Thank you so much for a wonderful session and
Thank
amazing
you.
interaction. So, with your permission, I'll wind up. And before that, I would like to tell that in feedback link will be coming to the chat box. Kindly copy, and you can just give us the feedback. Because with your feedback only, our team works very hard and get the person like Dr. Kannabiran Bhojan, type of pioneer person who always are a are respected, as well as the kind of, I can say, the best of personalities across the physio in India who are bringing the change. Thank you so much, sir, for joining us and giving us a wonderful presentation today.
Thank you.
Yeah, in your WhatsApp group, the feedback link will come. Kindly go through that and post your feedback. You can search upcoming courses on myrehabacademy.in, or you can be informed through the WhatsApp group. Our upcoming courses are, again, I can tell you there are many innovative courses are going on, like radiology for physiotherapists, especially the physiotherapist who wants to learn how to see the skeletal radiology, how to see the lung, how to see the CT, MRI, like what is your point of view? That course is already running. So that's how it is. And there are a lot of other kind of courses also going on. We are going to start something on the first aid also. We are thinking to give physio right from basics to advanced, everything they must, they like to learn and they must know that. Okay, thank you so much, participants. See you, sir. You can.
Yeah, yeah. Thank you so much. Yeah, we can wind up.